Hi, everybody. Thank you for joining us today. Uh, as we age, vaccination tends to be less top of mind, but that shouldn't be the case. Today's panel is going to review uptake, KT, vaccine education through policy insights and innovative strategies. I look forward to today's discussion, not only for personal reasons, so it was a few years ago I entered the 50 plus group, but also for ways that I might be able to support public health. As a reminder, feel free to use the chat function, introduce yourself, say hello, offer some of your personal opinions and thoughts. But if you do have a question for the panel, please use the Q&A function down near the bottom. It was about, I guess, 3 years ago that I met Bill Dempster. Learned a lot about his organization, 360 Public Relations, and its support for the Canadian health sector. Bill and Joanne Chambers have built a great organization with a strong focus on government relations and policy in the healthcare sector and life sciences. It is easy to find them on LinkedIn. I suggest at a minimum you should connect to that. I am a strong believer in building your network. You should feel free to reach out to people and connect. And even if you have no pressing need, you never know when you might be able to learn something from somebody. Okay, so you're not joining today to listen to me ramble on, so it is my pleasure to hand over the show to William, or better known as Bill Dempster. Bill, all yours.
Thanks so much, Matt. And thanks to the team at Longwoods for making this event possible, as well as Merck Canada for its financial support to Longwoods and for helping organize this webinar. So as Matt briefly mentioned, with Canada's age demographics shifting constantly, policymakers and science hubs have invested in strategies that can better serve our social, economic, and healthcare infrastructures that are increasingly stretched and strained. In that context, everyone is looking for solutions to help solve for primary care crises and health human resource challenges and issues. And I do think that's where this conversation can play a role. And as Matt said, really hoping that a lot of the delegates who are coming out here and participants are going to be very active in the chat. So please get your questions ready and bring them forward as they come up. I'll do my best to get to them. Sometimes I'll consolidate them, but we'll save lots of time for discussion. So yes, we know the vaccine is a cornerstone for public health. We've got three incredible experts to help kick off a discussion on where we stand in Canada regarding the current state of vaccine uptake, knowledge dissemination, vaccine education, and even the potential future for more precision immunization. We're going to start with Dr. Ronald Grossman. Ron is professor of medicine at University of Toronto, previously served as chief of medicine at Credit Valley Hospital in Mississauga. He's published nearly 100 articles with a big focus on respiratory tract infections. Of great relevance to today's discussion, he's been part of the creation of guidelines and the management of community-acquired pneumonia. Needless to say, we don't have enough time to review his entire CV. The main point is that Dr. Grossman is going to walk us through the state of the art in adult vaccinations, what's available in terms of technology. And before I hand it over to you, Ron, I'm just going to quickly explain where we're going. After Ron, we're gonna hear from one of the most dynamic speakers I've ever had the pleasure of seeing in action. Laura Tamblyn Watts is the head of CanAge and a leading advocate in Canada for the rights of older Canadians. Laura is going to shine a spotlight on innovations in adult tailored vaccines and immunizations, and her updated report, Adult Vaccination in Canada, a cross-country report card. A key question for all of us by the end of this will be, how can we be in this position next year and have gotten a better grade for our jurisdiction? Because right now, Canada is not doing as well as we should be in terms of adult vaccines. And our final panelist is going to be one of the best representatives of the innovative vaccines and pharmaceutical sector that I know. Jennifer Chan is VP of Policy and External Affairs at Merck Canada. Jennifer started out her career as a bench scientist and really understands the science, but has helped bring that knowledge and experience to work with governments and stakeholders across the country to help ensure that the latest vaccines are available in provincial vaccination programs. So Jennifer will walk through Merck's recently published roundtable outcomes report on immunization, and its key recommendations for increased adoption and uptake of vaccines, and especially around adult vaccines. With that, I'm going to pass it over to you, Ron, to explain the state of the science of adult vaccines. Take it away.
Great. Thank you, Bill. It's a pleasure to be amongst everyone, and welcome. So I have exactly 12 minutes to tell you about this award-winning science that's been going on for decades. This is a bit of a challenge, but I think we're up to the task. So this is the impact of vaccination over the years. Many of the most common infectious disorders that affect children and adults have largely been eradicated by vaccination. So vaccination is probably one of the most important healthcare innovations that's ever been developed for human health. Other than improving your environment and improving food and making sure we have clean water, vaccinations is right up there amongst the most important interventions that have really made a difference in the human realm. And the impact of vaccinations are multiple, both in terms of children and adults. And this is coming from the Chief Public Health Officer of Canada from last year, just to highlight some of the benefits of vaccination. It decreases morbidity and mortality. People who get sick don't go to work, so we can prevent that. People who don't get sick don't need antibiotics. If they don't need antibiotics, we reduce the likelihood of having antimicrobial resistance. The costs of the healthcare system clearly are diminished if people aren't getting sick and aren't attending emergency rooms and getting admitted to hospitals. So the benefits of vaccination are multiple, and they've been proven over and over again. Despite that, our vaccination rates are rather, pitiful at times. So for adults, if you're looking at the one area that I'm going to focus on in the next few minutes, which is pneumococcal infection, less than half of eligible adults have been vaccinated. And in older adults, where the risks are really quite high, as I'll outline in just a moment, barely more than half the individuals who should be vaccinated are getting the vaccine. And in fact, most of those who have been vaccinated were vaccinated with an older vaccine whose efficacy has always been questioned. So with the newer developing vaccines, which are clearly more effective, only a small fraction of the at-risk population have been vaccinated. And we have a very, very long way to go before we can be comfortable in saying that we've done the best we can for our population. So there are a number of different vaccine technologies that have been developed over the years. Traditionally, live attenuated viruses, for the most part, have been utilized for vaccine development. Then with polio, we got an inactivated whole virus vaccine. More recently, we've started using subunit vaccines, which involves a part of the organism being attached to something that boosts the immune system, and then is injected in a human, and the human then develops antibodies against the organism and prevents infection. And that's the format for the pneumococcal vaccine I'll talk about in just a minute. We have vaccines using the poisons that some of these organisms develop, so toxoid-type vaccines. More recently, we've used a viral vector vaccine where the antigen of choice is attached to a virus which is essentially innocuous and then injected. The Ebola vaccine is of that variety. And as you know, in the last few years, we've developed mRNA vaccines, which are the basis for the COVID vaccines, and Moderna has developed an RSV vaccine using this technology as well. So multiple technologies, all of which have shown efficacy over time. This is the format for these subunit vaccines, where you take a piece of the organism. In this case, we're going to be talking about the pneumococcus. You take part of the polysaccharide cover of this organism, attach it to something that will boost your immune system. Usually it's a protein. So these are called protein conjugate vaccines. You then inject this combination of the adjuvant and the piece of the organism that you want your body to attack. Inject it, your immune system picks it up, processes all of this, then starts producing antigens, and then your body starts producing the antibodies, which are neutralizing it and will combat the infection. So that's the technology for at least pneumococcal vaccines. So I want to talk about the role of pneumococcal vaccines as one example of this technology. So this is what's happened since pneumococcal vaccines were introduced in children and in adults. So the pneumococcal vaccine, the very first protein conjugate vaccine, was introduced in the United States around 2000, and Canada came around 2004. And what you see for infants and young kids who got the vaccine first, a vaccine called Prevnar 7, there was a clear-cut decrease in invasive pneumococcal disease in children and adults and children and infants. So invasive pneumococcal disease in these individuals is usually either bacteremia or meningitis. So there's a dramatic decline in meningitis, a fantastic outcome. But if you look at the right of this slide, you'll notice that in adults, not a whole bunch has happened. Now, originally, the vaccine was only given to children, and there was some talk about herd immunity, where you vaccinate the kids, the adults don't get the disease. But the impact in adults has been, I'd say, less than dramatic, let's put it that way. And if you look at the burden of disease of the pneumococcus in adults in Canada, there's a lot of disease and a lot of morbidity and tremendous number of hospitalizations. So this is over 11,000 cases of community-acquired pneumonia, over 100 cases of invasive pneumococcal disease in adults. And you'll notice who's getting these diseases is people 50 and above. So the notion here is once you reach the age of 50, it's a very slippery slope thereafter. You will progressively develop weakness of your immune system, a concept called immune senescence. This is progressive, it is relentless, and we have no interventions that will alter the progressive weakening of your immune system. So as you get older and your immune system weakens, no surprise, you see the development of disease, which is basically age-related. On top of that, once individuals get pneumococcal pneumonia or invasive pneumococcal disease and they get hospitalized, a significant proportion of them will develop the need for an admission to the ICU, which is with its inherent costs. Some of them will require mechanical ventilations, and mortality rates are significant. You'll note, by the way, that ICU admissions and the need for mechanical ventilation actually occur in people who are not that old. The ages, 50 to 64 are really the dominant ones, whereas the mortality rates tend to be higher, obviously, in the older individuals. So who's at risk for this disease besides the elderly? The answer is virtually everybody. If you have a significant comorbidity like COPD, asthma, alcoholism, diabetes, chronic renal disease, chronic neuromuscular disease, your risk of pneumococcal pneumonia goes up dramatically compared to someone who is older but has no comorbidity. So if you look at the two bars on the far left, the purple bar with the number 25 over it is the incidence of pneumococcal pneumonia in individuals between the ages of 50 and 64. The red bar represents people 65 and older. But look what happens if you have COPD in the middle. Your risk of pneumococcal disease goes up dramatically. And virtually every comorbid disease will do this. So why do we need a pneumococcal vaccine for adults? We've had this pneumococcal disease for the infants since, as I said, the United States since the year 2000. And the answer is because the disease in adults and the disease in kids are not the same. The organism, the pneumococcus, is not one organism. There's actually 100 documented variants. They're called serotypes. And some of the serotypes are shared between adults and kids, which are the yellow circles. But some serotypes are unique to kids, which are the purple circles, and some are unique for adults, which are the green circles. The size of that circle represents the likelihood of the pathogen causing disease. So in adults, as you can see, serotype 3 and serotype 22F are the major players. For kids, it's 22F and 19A. So they're different. So the traditional vaccine that we've used for pneumococcal pneumonia prevention is Prevnar 20, which was a vaccine that was developed for infants, and then gradually additional serotypes were added because this is a moving target. When you introduce a vaccine in kids and eradicate the original 7 serotypes, which was Prevnar 7, unfortunately, over time, other serotypes start to move into this biological vacuum, and you need to start covering for other organisms. So over time, Prevnar 7 evolved into Prevnar 13 and ultimately into Prevnar 20 because the serotypes causing disease changed. But all the while, the serotypes in adults were not the same. So the 7 serotypes in Prevnar 7 are shown on this slide on the top left. The newest vaccine that we have is called V116. It's called Capvaxive. And you'll notice it doesn't have any of the serotypes that are in the original Prevnar 7, the assumption being that those original serotypes were in kids mainly, and that over 20 plus years, there's population immunity against these serotypes, and we need something for adults. So you notice that the serotypes that are covered by V116 are quite different than the ones covered by Prevnar 20. And if you look at the efficacy of this new vaccine compared to Prevnar 20, which is a very good vaccine, you'll notice that this new one called Capvaxive will cover a greater percentage of the organisms that cause invasive pneumococcal disease in adults than Prevnar 20. And the difference is significant because invasive pneumococcal disease and ICU admission and frequently death. So NACI now recommends either of these vaccines, either Prevnar 20 or this new one, Capvaxive, as one dose for everybody who is 65 years of age or older, and they recommend it for individuals who are under the age of 65 but are at risk for invasive pneumococcal disease, like the bad diabetic, the bad COPD patient, et cetera. But the technology is changing dramatically. And we're seeing the evolution of new vaccines with ever more serotypes being covered, new technologies to allow us to cover for more of these serotypes, new ways of giving these vaccines. So many things are changing, and the future looks quite bright. These are some of the vaccines that are in development, a 24-valent vaccine, a 31-valent vaccine by different companies. They're all in late stage development, and you'll be hearing more of this. So this is an ever evolving area. So let me conclude. We think the burden of bacterial and viral disease is ever increasing. Clearly the older individuals at risk, but those who have compromise of their immune system, those who have significant comorbidities also are at risk. The vaccine technology is changing day to day. So it's an exploding technology and it's hard to keep up. We have clear-cut evidence of vaccine efficacy, and the benefits of vaccination have been documented for a very long period of time, but not all of these vaccines are covered. And so the question is, why isn't everyone at risk vaccinated? And why aren't recommended vaccines covered as well? So I'll stop there and turn it back over to Bill. Thank you.
Thanks, Dr. Grossman. That was excellent. And I loved how you entered it on a question that is going to be taken up with vigor by our next panelist, who has spent a lot of time researching and reviewing what's happening across the country. So, Laura, why don't you walk us through the state of adult vaccination in Canada and what your research has found, and where you think we should go next.
So great to be everyone here today, and I loving hearing in the chat. Please introduce yourself. Tell us a little bit of what you do. We can make sure that we informally chat with you and even answer informal questions. And formally, of course, you've got the Q&A process, but we love to hear who you are and what you do, and we can help to tailor our thoughts around that. I don't know if you know, but it's apparently election season in Canada, no matter what you do. And for those of us joining from Ontario, you'll know our snap election is upon us. And of course, we have the ever-changing federal landscape, and we still have a lot of blinking into the sunlight coming out of our BC elections, and there's lots and lots of issues. But what's really important is that vaccine and vaccine funding and the structures to making sure that the vaccines come through into Canada in a quick and appropriate way, that we don't lag or other countries end up buying our vaccine supply because there's lots of other places that want it. These are voting issues, right? And it's really important to remember that my organization, CanAge, is an organization of voters, but we're not only interested in seniors issues, we're looking at all vaccinations because, as you know, while there's implications for older people, this is very much a life course. Anyone who came back from the holidays and hugged the toddler and then went to visit their parents who are 88 years old knows very well that, the RSV was something real, the question about pneumonia, and of course, good old COVID on top of flu season. So these are really, really critically important issues. And we need to make sure that they are voting issues as well. Although I would like to point Dr. Grossman's underscoring, these shouldn't be actually issues with regards to politics. These should be just good public health. And yet, if you saw what came out of the report in Alberta recently, and if you haven't, I'll put it in the chat later, it was a very unusual, that's the kindest way that I can put it. And I'm not always quite so kind on that. It was a very unusual way of commenting on vaccines. It was something very resonant out of our Trumpian American colleagues. We really haven't seen a political report like that on vaccines and vaccinations. And I think that has to be called out as a bit of a worrying trend. This is just my little disclosures. We're an independent organization. It doesn't cost anything to join CanAge. We are working to support all Canadians as we age. Look, I also teach. And when people tell me that at my students that the world is rapidly aging, Canada is rapidly aging, the province is rapidly aging, I want to kind of shake them a little bit because it's not a silver tsunami. Obviously, they don't know what tsunami means. A tsunami is an unexpected wave that crashes upon you and then goes away. And that's actually not what's going to happen. We're not aging more rapidly. We're aging at exactly the same predicted rate that we thought we would. We just didn't do anything about it, right? So that's an important thing. And it's not going to just come and go. I'm in that skinny little bit in the middle there, that Gen X generation. But you'll see that the millennials behind it are, in fact, bigger in some cases than the boomer generation. So this is not a one and done kind of trend. What it does mean, though, is that there's profound economic aspects to this as well as time. I don't know. And I'd love to see in your chat, does anyone consider themselves, in that, it used to be called the sandwich generation. I call it a club sandwich generation. You got kids, you got older adults, but you probably also now have, grandparents that you might be supporting as well as other relationships. It's important to remember when we're talking about caregiving and care support that we're talking about people in the economy or not in the economy, people spending money on trying to help provide help and care and support. 75% of all care is actually provided for free. That's really important because that's not in our formal healthcare system. And when we're thinking about these types of supports with vaccinations, we have to remember, how did our economy do during the pandemic? Not so well. And that's because if you don't have people to work, your economy grinds to the halt. And yet, this is exactly the lesson that we need to remember again, as those of us in those skinny generations, or any of them really, are now, and I hate the term burden of care, are now going to be looking after 4 to 6 older people or people who have significant health needs over the course of our lives, all while trying to do something else at the same time. You know what really helps is when your grandkid comes and hugs, your family member, if they don't transfer RFC, if they don't transfer pneumonia, if they don't transfer flu or COVID, and that needs to make sure that we're really thinking about this. Yeah, we know this, but sometimes it's good to have a little look at it, right? We're already 1 in 5 people over the age of 65. And it's important to remember that when we're tailoring vaccines, a kid's vaccine is not the same thing as a vaccine for an older person, as Dr. Grossman was talking about. A vaccine for somebody in their 40s and 50s is not necessarily designed specifically for an older person. And when we're thinking about the incredible innovation that we have already in the vaccine space and where we need to remember we need to have vaccines to suit the needs of people. And this is a bit of a look in it. We know this as well, but I really just want to draw attention to the fact that there's going to be 3.3 million people 80 and over, right? 3.3 by 2036. This is a huge number of people, not 65, not 75, over 80. And it is critically important that we keep those people healthy and well. Then what does that look like in terms of percentages of population? Well, these are doubling of the populations in some of the aging areas. So this is no joke, particularly if you identify with some of those rural areas. This slide doesn't really show it in great detail, but just look up in the territories. That's how many times we're going to see our rural communities. Critically important. Where we don't have good healthcare? Rural communities. Where we don't have good acute care supports? Rural communities. So 65% of Canadians who are living in rural communities are seniors, 65%, and that number is also going to go up. So if we're trying to think about what are we going to do, this is really important. I want to talk a little bit about some of our submissions. I threw this up here because we want to see that all vaccines get bought by the federal government and distributed to the province. We've been saying this a long time and always got that finger pointing that we get, as you know, oh, well, in a division of power. No, we did it during the pandemic just fine. The federal government bought COVID, gave it to the provinces and territories, and it was distributed, and it was a success. 2025 is the year that provinces now have to buy COVID vaccines, in addition to try to figure out how they're going to have their public health dollars expand in the areas of things like RSV, right? A newish vaccine, the new and innovative pneumonia vaccines, the new and continually innovating, flu vaccines. And I really don't know how we're supposed to be doing that. So I think it's going to be critically important that we do that. I want to just very briefly, if I could use some words about policy and advocacy. When we talk about policy development, I'm thinking about how we together can identify a problem and solve it. These are the policy discussions, but I said, look, there's an advocacy element, and we are at that forefront. We want to join with you all to make those third-party changes. I can't myself make, NACI get renovated into a more effective and, more efficacious organization. They're good people trying to do good things, but we didn't set it up for what it needs to be right now. Our review board systems aren't set up for what it is you need right now. And we need to make sure that we get that connection of policy between that marketing and communications point. And so we spend a lot of time working with government and community trying to get those pieces of information as well. We do that by showing a few of our roadmaps and so forth, but we also do that by trying to get some key messages. And these are some of the ones I just want to briefly share with you and close. The nursing hours spent caring for preventable, just pneumonia, I didn't even do it for everything else, just pneumonia, could staff 5 major emergency departments 24/7 for an entire year. I didn't put any pretty pictures on this. I put this in block screaming letters. So you want to figure out how we can get acute care? This is again, hospital impacts. So average stays for influenza can be up to 14 days, for pneumonia, 6 to 10 days for complex cases. But almost 22% of cases require intensive care. And if you decondition after 3 days in hospital, you're immediately going to have problems with getting people to go back into the community. We know that home care is already a hugely problematic system. We need so much more of it. We don't have it. And then what about long-term care? Well, if you've been hospitalized with one of these vaccine preventable disease, this is again pneumonia. 1 in 6 seniors require placement in long-term care just because of the vaccine preventable disease. And I'll close just with this. Complex cases, as we're having increasingly complex issues, are going to cost our healthcare system like $21,000 again for a preventable issue. And if you've got intensive care, we're doubling it to almost $42,000. Every single day's prevention could cost $3.5 million in savings just for pneumonia as well. And if you want to put it into nursing positions, now, of course, we still need to get the nurses. That's an entirely different conversation. I want you to look at that number. 12,700 new nursing positions could be funded if we did that. So just wrapping up, we want to make sure that we're both getting clean systems through so we can get the best vaccines to the right people in the right arms in an effective way. But we need to make sure that we're making those connections, not an either or between hospital and vaccines, not an either or between home care and vaccines. It's vaccines that save the other things. And we want to make sure that this is communicated in an effective way during this election.
Fabulous. Thanks so much, Laura. It just flashed briefly on the screen, but your report card, I'm going to maybe want to come back to that. I don't know if you want to talk to that right now and flash it back up, or if you want to save it for the discussion.
We can say this, just been brief, every year we do a review, and this will be our 5-year review as well, to see how it is that we do across the country in terms of reports. What do we fund? And most people can't get their head around the fact that we don't fund everything all the time. And we look to see, what gets funded versus what NACI recommendations are. So we're not trying to say what we think should necessarily be funded. We're looking what NACI says. And you will see that there are, huge problems in how we do it. We also put some specific communities. You won't be surprised to know that, new Canadians, people who are unhoused, folks in Indigenous communities have a really different and lower uptake rate. And I just want to show you this. Thank you for the opportunity. Sometimes we think, oh, we're doing a good job. And here's an example of BC's where, even if they were, doing a good job, pardon me, in Ontario, I'm going to look at Ontario versus BC. BC's awareness is fantastic. We have all kinds of awareness, great public information. But if people can't get a hands on the vaccine, if it's not funded, if they can't get access to it, doesn't matter how good the information is. By corollary, this was an example of one of the screenshots from an earlier report card where you see that Ontario did a really good job pretty much in their funding and awareness, but you couldn't get your hands on the vaccine. So the access really fell apart. What we need to make sure is, as we're reviewing things, that we make sure that information is crisp and clean, but that primarily it's publicly funded and that people can get those vaccines in a really, really easy way. We've done it before with COVID, and we need to make sure that we do it again on a constant basis at a time where often we're being made to make these false equivalencies. And it's not either or, it's vaccines saving the day for the rest of the healthcare system and, frankly, the rest of the economy.
Amazing. Thanks so much, Laura. That's great. Really appreciate you bringing that back out, and I'm sure we're going to get to some of the discussion on that. So, Jennifer, talk to us a bit about the roundtable and some of the themes that came out of that, because it was multi-stakeholder. We've got a few stakeholders here, and honestly, hats off and kudos to the chat, and please keep that up. We see some amazing people from across the country. Beth, Amanda, you know who you are. It's actually, I'm looking forward to being able to see some of you in person. Keep the chat going. But Jennifer, why don't you reflect on some of the outcomes from a multi-stakeholder roundtable that Merck helped put on recently?
Sure, great. Thanks so much, Bill. And thank you, Dr. Grossman and Laura. I always learned much listening to you. So yeah, thank you so much for helping to set the stage. And good morning and good afternoon, everyone. It's really nice to be with you all today. So as we've heard from Dr. Grossman and Laura, and we clearly know that vaccines work, and they are the most important tool in the public health toolbox for preventing infectious diseases. So here at Merck, we've invested in Canada and around the world, really focused on finding, developing, and deploying vaccines. And we've been doing this for many decades. And vaccines are a core part of what we do, but we couldn't do it without leading clinical experts and civil society leaders. So just because we have been developing vaccines for so long, it doesn't mean that we have it all figured out. And as you heard a lot from Laura, there are major gaps in terms of how and why at-risk populations, including our seniors, are not protected. And so we know that we see immunization coverage rates all across Canada between different populations. It really varies. But the report card that we just saw clearly shows that we've got a lot of gaps and we need to figure out how to do better. And so when we look at pediatric pneumococcal vaccination, as we heard from Dr. Grossman, it's great. We see high rates for pneumococcal pediatric vaccination in the high 80s, but we're really far from achieving adult immunization targets when we look at the older population, the adults and seniors. So I think we really, really need to start focusing in on and looking at a life course approach to immunization, and really, focusing and prioritizing adult vaccines as seriously as we do for the children's immunizations. And so with that in mind, and as Bill indicated, we're really, really hopeful and really love to be able to be part of these types of events and discussions to really try to help identify and socialize and really look at some concrete solutions so that we can help address some of these gaps. And so for this reason, as Bill mentioned, we recently worked with the health policy strategists at Santis Health to convene a roundtable that brought together different perspectives, folks from federal and provincial officials, folks who are particularly focusing in on public health agencies, clinicians, and patient leaders, to really come together and collectively discuss and align on how Canada can increase vaccine coverage rates across the country. And so as you see here on the slide, we want to share some of those learnings with you today and some of the things that we've learned along the way as well, and really hoping that everyone can think about this and leave today maybe with one or two concrete ideas of what we can do to really boost vaccine uptake. And so with that, there were 8 themes that came out of the roundtable. And so maybe I'll just get started here. So the first one is healthcare. And we know that healthcare is sometimes overly focused on treatment, and there's not enough focus on the prevention piece. And so, and what's really, really important is we can actually measure the value of prevention now. We know that, as Laura indicated, it's a huge boost to the economy, and it can help free up other health resources when we actually increase immunization rates. So recently, there's been a recent study that was actually done by the health data firm IQVIA. It was commissioned by the Adult Vaccine Alliance. And their study actually found that for every dollar that was invested in adult vaccines, that actually returned almost $3.50 more into the health and economic system, and brought health and economic benefits. So clearly, there's a value of prevention. The second theme that came out of the roundtable is the need to really boost access to vaccinations and facilities. And when we look at for many older Canadians, including those that are in long-term care homes, we know that that they are under-vaccinated, and so one of the solutions that was discussed is really to fund vaccine programs properly, enhance the role of the primary care providers, and really expand the role of pharmacists to be able to prescribe and administer vaccines. And if we can provide them with training and the authorities and really empower the pharmacists, we can really look at an opportunity to streamline that whole vaccination process and provide patients with more points of care and to help them navigate and reach the vaccine. So again, proposal for looking at regulatory changes that would facilitate the seamless access to all recommended vaccines through pharmacies. That ultimately, I think, will help to improve, could help improve health outcomes for Canadians. The third thing that came out is really the theme about science communication and the need to build a better trust. And so we know that effective communication is really, really important in building trust and combating, all the misinformation. And the COVID-19 pandemic highlighted the importance of that, of both, clear, transparent communications, but also empathetic public health messaging. And so this also means being able to provide timely updates on scientific findings and really providing the reasoning behind public health decisions and recommendations. On our part here at Merck, we've been really, really proud to be able to partner with the Delavan School of Public Health to do work in this area and to really help drive that public discourse on the benefits of immunization, including for older Canadians. The fourth recommendation coming out of this roundtable really focuses in on data and really the opportunity for Canada to have centralized data and registries. And so right now, the lack of centralized efforts to be able to track various types of vaccines really leads to inconsistencies in data collection and reporting. And we can even look at the provincial level, the opportunity to improve provincial vaccine registries. And this will really help us to identify underserved populations, and so that we can focus and target vaccine education and distribution to these communities. Fifth, we need to figure out Canada and how to handle the jurisdictional silos and responsibilities. And as Laura mentioned, we are an incredible, a wonderful nation federation, but we really do need national frameworks that would provide for accountability and standards for vaccine access and delivery. And provinces and territories can also benefit from greater collaboration and really being supported from a coordination standpoint by the Public Services and Procurement Canada, or otherwise known as PSPC. And PSPC really serves as a coordinating body, and their mandate really aligns with the provincial healthcare directives to look at, the opportunity to streamline vaccine procurement and delivery. Sixth, certainly, we know that we need clarity on who is responsible for funding. And I'm watching some of the comments in the chat as well, is that if we recall, about two decades ago, the federal government implemented the National Immunization Strategy. At the time, it was really ambitious. It set up, vaccine targets, and it was really well funded. So I think the economic case really exists, for Canada to look at a similar funding approach. And could we think about, in that, adopting a life course approach to really close that gap between, the childhood vaccines that are funded and adult vaccines? And so we know that, improving vaccine uptake in adults, it can lead to really, really impactful benefits. So I had mentioned earlier about the report that was done by IQVIA. They also studied this and looked at, the impact of this. And what they demonstrated in that study was that if we looked at a 10% increase or boost in the immunization rates, this would drive, more than $700 million in health and economic benefits. So clearly, the economic case is there. Seventh theme that came out of the roundtable was really the focus on innovation, research, and vaccine development. And we heard a little bit about that from Dr. Grossman. And again, this isn't going to be anything new for, I think, all the folks online here in terms of, there's a lot of scientists, researchers, policy experts, public health experts. But I think it's really, really, really important to repeat this, that Canada really needs to foster an environment that encourages innovation and looking at, streamlining regulatory processes to help bring, the innovative vaccines, through the regulatory processes and into the arms of patients. And there's all sorts of other mechanisms as well to look at funding innovation and through competitive tendering opportunities, the opportunity for provinces to be able to bring the best and latest vaccines forward that have been Health Canada approved and actually recommended in a way that's cost effective. So again, what we did hear very, very clearly from the roundtable is really look at developing immunization strategies that can look at all the innovative vaccines that are coming through the pipeline, but also ensure that these strategies are really catered to the community and the demographic needs of the populations. And so again, thinking about the adult and seniors vaccines and really, really thinking about, now the opportunity with the newest vaccines to be really focusing in on, the approach of having adult specific or adult targeted vaccines available now. So 8th theme, and I'm going to continue moving quickly on this one. Again, we need to really ensure that immunization education is really well integrated throughout society. And the roundtable really highlighted, again, the big theme about trust as being a major gap, and that the experts recognize that we need to communicate about vaccines differently, talking about them clearly, consistently, both the benefits and the risks. And so really looking at integrating vaccine education really importantly into the school curriculum, but also, really leveraging social media campaigns and really, working and collaborating closely with community organizations and to help, dispel myths and really ensure that the messages are tailored to the specific demographics where the gaps are. So just to conclude, and before I turn it back to you, Bill, is I think the key takeaway from this roundtable when we left was that it literally is going to take a village to come together to get a better report card for Canada in the future. It's clearly going to take a multifaceted approach that's going to look at education, improving access to vaccines, including vaccines for our adults and seniors, and really effective communication overall. So I think with that, really looking forward to the panel discussion and your questions. And so I'll hand it back to you, Bill.
Fantastic. Thanks so much to everyone. And Jennifer, that was a great kickoff to this discussion, and I know it actually led to a lot of chatter online. We were going to start this with a bit of a discussion on, okay, now what, and who needs to do what among the stakeholders. And Dr. Grossman, as a treating clinician and somebody who is, part of what I think Dr. Naylor called the guild at one point in terms of physicians. Things seem to be changing in terms of healthcare professionals and how they work together with across the full range of who is actually seeing patients and treating patients. Where do you think clinicians need to move to on vaccines to actually move the yardsticks and get Ontario from a B to a B plus or BC above a D? Like what can clinicians do on this? And if you've been following the chatter, it looks like pharmacists have really put their hands up and said, "Hey, we can tag in here. We just need some more funding and guidance on that." So, what are your thoughts, Dr. Grossman?
Well, things are clearly changing. I'm a specialist, and I've never given a vaccine in my life. Personally, I've always, when I'm writing letters to my physicians that are sending me patients for comments, I recommend the vaccine, but I've never actually given it. That's changing. many of my colleagues, specialist colleagues, are now actually vaccinating. They realize the benefits of vaccination. And whereas previously they would just write maybe a note, vaccinate my patient, or more often they wouldn't say anything. Now, as a routine, they're recommending vaccination, and many of them are actually giving it. So that's in the specialist community. In terms of the primary care physicians, the thing about the primary care physicians is they need to be the champions of vaccination. The one group of individuals in this country that the population trusts are the primary care physicians. They often have a long-standing relationship with them. They've stood by their side over long periods of time, and they trust them. So the key, I think, to a lot of this is to make sure that the primary care physicians not only recommend vaccination, but they are champions for vaccination. They really have to be believers. They have to be proselytizers. They have to be, the priest up there on the platform praying and urging their individual patients to do the right thing for themselves. And I think that's an important aspect of it. So clearly, primary care physicians are critical to all of this. And what do you do for the individuals who don't have any primary care physician? And that's where I think some of these other providers become really important. The pharmacists and other healthcare providers that have access to individuals, or the individuals have access to some aspect of primary care, not through necessarily a primary care physician, but they need to be champions of this as well. And the key word here is champion. They really need to be proactively supporting the use of vaccination as best they can.
Yeah, thanks so much. And we, shout out to Shalita Datani from Neighborhood Pharmacy on the line too, who, I would call her definitely a champion for better vaccines. And look, she just posted again. So we've got certainly a champion pharmacist and on the line. Any other thoughts from others on clinicians? And then I want to go back to you, Laura, in terms of you did this in terms of governments not actually, stepping up. But any further thoughts on clinicians? And then we can talk about how governments can actually say this and step up, and we're going to get at it. So before we move on to politics.
I think clinicians is a really important thing to talk about, and it's that all hands on deck approach, right? And I just love that Dr. Grossman was talking, I have my job and you have your jobs, and we all kind of assume that vaccination gets done by somebody. Like, I really do believe that there's a general desire in the healthcare supports to people to get vaccinated, but the reality of the circumstances, if you actually get somebody at a point, whether it's a healthcare hub being so often a community clinic, whether it is going to increasingly be multi-discipline teams, particularly where we're in stark need of GPs, it has to be while anyone is at a point of connection that you get that vaccine conversation going, and it not just be I'm not really so sure. Do I need it? Do I not need it? But there be the information right there that we have this kind of inundation of messaging. And we've seen this in other jurisdictions. Look, in Brazil, they have one day a year. It's National Vaccine Day, and everybody gets time off work and everybody gets vaccinated. That's the way that Brazil decided to do it, and it's hugely helpful. We've seen other initiatives like in the UK, where every time you get a prescription, the little bag that you get with your prescriptions, it says, have you been vaccinated for the flu, whatever, find out here, book your prescription every single time. And we know that those types of repetitions and multifaceted points are the key. But on the whole, every time we put that down the line approach into it, I need a prescription to get a vaccine, I need to pay a dispensing fee, I've got to go back to the doctor to get the vaccine that I've had to order, it just doesn't happen, and people can't do it. And very unequally, if you can afford to get it, you might get it. But that niche amount of people in terms of ability and inclusion goes downhill. We need to take that everyone, everywhere approach personally.
Yeah.
And
Laura,
another point, just before you go on, one of the opportunities that is always missed is the individual who gets hospitalized. There was a time when there were sort of automatically, if an individual was admitted to hospital, they would get a pneumococcal vaccine before they went home. That was quite a long period of time ago. Nowadays, nothing happens in the hospital. And that's a perfect opportunity. You have someone there for whatever reason they're there. And why wouldn't you vaccinate? The problem is that the hospitals have to buy the vaccines. They don't want to. I mean, there's a cost for them, right? So it becomes a problem of acquisition of the vaccines and the administration of the vaccines. But hospitalized patients are a perfect example of an opportunity missed.
And that's it makes me think of the Ottawa smoking cessation model. Started in Ottawa. If you get admitted, you're going to be, getting access to ability to stop smoking. Why don't we have something like that for vaccines? And that just, of course, took off as a best practice across the country. Jennifer, you're going to jump in.
Yes, and I just, building on Dr. Grossman, you were talking about, the kind of, points of care, right, for patients and, the opportunity for pharmacists. Laura, you're talking about, navigating that patient journey to reach, vaccine in arms and, getting the prescription, having to go back, see pharmacy, all of that. But thinking about, and maybe this is, a concrete and a shout out, potential opportunity for Ontario, really look at expanding the authorities for pharmacists to be able to prescribe and administer vaccines. And again, thinking about, healthy competition, if you look at, kind of other provinces, the authorities are there for pharmacists to serve as a, point of prescription and access for our adult and senior patients. So thinking about, let's get going in Ontario. Let's make this happen.
Excellent. And one thing, Matt is mentioned this in the chat. There's so much information and thoughtful, questions and comments in the chat. We will do our best to summarize a lot of that and bring it back out to all the participants. So thank you. Keep it up. Let's move on to governments and policymakers. Laura, you mentioned we're in the middle of a pretty big political storm right now, from Ottawa, where I am, to of course Ontario, and an election next year in Quebec. Not to mention the firestorm that's coming from the U.S. and that was referenced as well, I think, by Dr. Eber in the chat. In terms of who does what and that finger pointing, what would you say to turn those fingers back and say, you know what, we're going to step up and do something about it? Any initial thoughts there?
Well, for me, I have to say the goal should be all vaccines completely covered. Everything that NACI recommends should be completely covered as part of national pharmacare. I mean, that is our stand. And I think that we need to also understand compassionately that the folks who are staffing NACI are doing so out of the goodness of their heart and the excellence of their profession, right? But the whole system wasn't set up for this. You just can't compare it to the existing US or EU or even some of the South American systems. Like, we just didn't. They're doing this off the side of their desk, really out of professional support. So we just can't do it in that way anymore. We need a revamping of NACI, and that's a federal piece that we need to think about. We need to really think about that. And for the nerdy policy folks, I'll use the acronym, but the PMPRB, right? Any of the review board stuff that comes through, we have the longest review process in any comparator country. Like, we're just so years of review, particularly on vaccines, where price is actually not the issue. This is not one of the matters because it goes out for tender. So having it going through these old crunchy reviews is just ludicrous, particularly at a time where we need innovation. And we need also a combination of domestic and foreign purchasing as well. We know that we need that, and making sure that we have those things as available. So all of that is federal. Provincially, though, wherever we are right now, we need to make sure that we bend our knees a bit, because not only do we need to be able to make sure that we keep our people more healthy and more well as we're becoming increasingly frail and increasingly complex and increasingly old, but they also have to make room for RSV now, and they also have to make room for the new pneumonia, and we have to make room for innovation, and we have to make sure that also that they can afford COVID. And yes, it's true, Mark Holland ran across this entire country in his little running shoes and did, major healthcare deals and tried to put money into the provincial systems. But the provinces were given money in those transfer packages. So any province that says to you that they don't have money, it's nonsense. It's all about, will it be allocated? And that's where we need the advocacy right now.
Yeah, that's excellent. Jennifer, we had a good question in the chat about how vaccines are paid for by which level of government. I don't know if you mentioned earlier about PSPC, and there's actually a really good infographic on PHAC's website, but can you just explain briefly who pays for vaccines in Canada in general, outside of COVID?
Yes. So in Canada, it's at the provincial level. So vaccines are funded by the provinces. And so the Ministry of Health will make the recommendation in terms of, which vaccines they will fund for which populations. So I think, and so I think it's, kind of anyhow, biting an elephant one piece at a time and just coming back, Laura, and I'll come back to Bill, your question about this wonderful federated system that we live in. And it really underscores, and I know all of my industry colleagues, we talk a lot about this and we want to be part of this solution, is, how do we bring like the federal processes together with the provincial processes, because everything takes time, right? You have to be able to kind of have this longer term view and scan the horizon in terms of, what new innovative vaccines are coming, and then make sure that, budgets are allocated or go seek the funding for it. As, Health Canada is doing the review and NACI is doing the review. So how do we look at all those steps in the process and make sure that they're well coordinated so that there's, not years of lag, frankly, between the time that, Health Canada deems a vaccine, it's effective, it's safe, NACI makes a recommendation, provinces should use this, to when it actually, a public program is, kind of announced and funded. And so, as Laura indicated, we really, really need to do much better in Canada. But we can't do this in silos, and we need to be able to find a way where everyone involved in that whole journey can sit together and kind of look at where things are lagging, taking too long, and find a way to kind of make things work better and be more coordinated in Canada. So we really have to find a way to break down those inter-provincial, federal, provincial silos.
Yeah, when you're talking, it makes me think of like follow the bouncing ball, right? So remember that? I'm dating myself. But Health Canada authorizes a new vaccine. NACI looks at it and says this should be used in this patient population at this time. Provinces provide the signal back to, I guess, PSPC, the federal negotiator for a common procurement price across the country, or common procurement agency for all intents and purposes. They get an allocation back in the provinces, and then the program gets into play. It seems like it's almost like a hockey game where you're passing the puck back and forth, but they're not running the plays very effectively. And then at the very end of this, you're hoping that you're going to get access to a vaccine that's maybe funded. I mean, I paid for the shingles vaccine that I went through the course of recently. Laura, are you hearing from a lot of your members across the country about just saying, what the heck is going on? Why do I have to pay $200 for this?
Oh,
This
listen.
one was free.
Yeah, listen, the price and access are really the biggest drivers. Information is going to be important. It's an ongoing thing, but it's not just information, it's trust building information. It's meeting communities where they're at. It's answering questions in safe ways and those types of things. But what we know is this: prices are skyrocketing. People who are especially living on a fixed income, that delta between how we calculate what they need and actually what money they get is expanding. It's a whole nother long width discussion. Happy to have that one there. But what it means is people on fixed incomes are having a harder time stretching it, and that's going to continue. And the first thing to go is anything that they have to pay for that's typically health-wise, right? So dental was one of the first things that would go out the door. Now we've got some supports on that. It's vaccines. People say to me, okay, I could, spend somewhere between, depends where you are, like $240 to $300 on shingles vaccine. Or I could try to get the flu, like the good flu vaccine, the best flu vaccines for me, the high dose, the enhanced ones. I could, try to get a pneumonia vaccine. I can buy these things, or I can have heat, or I can have food. Like, we're not at the, maybe I go to a movie version, right? We are at the bottom of Maslow's hierarchy. And these are not conversations where vaccines should be. They should be fundamental. And yet that's what's happening. People right now are making the choice between heating and eating. And I can tell you, their poor health is what's going to eat up our public dollars. So the best and most effective thing we can do is fund all NACI recommended vaccines and get them into the arms of people who need it. That's what's going to.
And I just wanted to make a comment on that. Laura, if we look at healthcare budgets of Canadian governments, of what they're funding for vaccines, NACI recommended vaccines, it is less than 0.2% of the overall healthcare budget. So exactly to your point, prevention needs to be prioritized and the funding needs to follow.
Yeah, I was going to make a comment that I don't have the exact number that Jennifer has. I was saying that vaccines are going to be less than 2% of a drug budget of a province. It's really, really tiny. It's nothing compared to the overall drug budget. The other point I'd like to make is that, Laura actually made it earlier, I just want to reiterate it, that NACI is a broken organization. It really is not good. The problem with NACI isn't the people on it. They're fantastic people. And as Laura said, they are volunteers. They are not paid. So there's a timing issue about when data arrives and when recommendations are made. I'll give you an example. When Prevnar 13 came out, that came out in 2013. Within a few weeks of the randomized controlled trial demonstrating the vaccine's efficacy, the United States had already changed the recommendation. It took NACI over 2 years to make a recommendation after the introduction of the data that clearly showed that this vaccine was superior to anything else we had. More than 2 years. I mean, it's unbelievable how long it took. And provinces use NACI as an excuse not to vaccinate. They're always waiting for NACI to tell them what to do, but NACI is not timely. And that's got to be a fundamental reform if we're going to do better.
Excellent. Thanks so much, Ron. I saw Matt, you jump on the screen, which means you might have that big shepherd's hook to say, hey, we're at time and people can. No, not at all. This has been a great conversation. And, again, special thanks to everyone in the chat. Matt, do you want to help close it out?
Yeah, just a couple quick final comments. Again, I'll remind everybody that I will collect all the chat. I will put it together for the speakers, and there may be opportunities for further commentaries. We know maybe events will come out of this, who knows, but I will put that all together and we'll share it with the group. Other than that, fantastic conversation. Glad to see everybody and have a wonderful day. Take care. Bye-bye.
Thanks, everyone.
Bye-bye.